Good afternoon, everyone. My name is Kristen Sue. I'm the Executive Director of Research at the Amyloidosis Research Consortium, and I am delighted to welcome you to today's ARC Talks webinar focused on approaches to treating relapsed and refractory AL amyloidosis. We are honored to be joined by Dr. Heather Landau, Associate Attending Physician and Director of the Amyloid Program at Memorial Sloan Kettering Cancer Center in New York. She's also an Associate Professor of Clinical Medicine at Weill Cornell Medical College. Dr. Landau's career has focused on improving outcomes for patients with plasma cell disorders, including both multiple myeloma and AL amyloidosis, where she has led multiple investigator-initiated trials, is currently a co-chair for the Center for International Blood and Marrow Transplant Research Working Committee for Plasma Cell Disorders, member of the International Kidney Monoclonal Gammopathy Consortium, where she leads the Renal Transplantation Working Group, and is recipient of an American Society of Hematology Bridge Grant for her work on proteomic approaches to minimal residual disease. Now, for those of you who are new to the ARC-TARCS webinar series or to our organization as a whole, welcome. We're so excited that you found us. ARC is a patient-led, research-focused nonprofit organization that works with and across all stakeholders within the amyloidosis community, harnessing the power of collaboration and innovation to advance science and both improve and extend the lives of those with amyloidosis. We pride ourselves on being a science-based patient organization working to de-risk drug development by strategically implementing programs that we believe are critical to better care for patients and facilitate and accelerate drug development in these rare diseases. ARC's outreach and education inform and empower patients, families, caregivers, physicians, and researchers. The 4 pillars of our work are built around improving the speed and accuracy of diagnosis, increasing the understanding of the genetics, biology, and natural history of amyloidosis, accelerating regulatory approval and reimbursement of treatments, and enhancing the care and quality of life of patients. Now, before I hand it over to Dr. Landau, I would like to send a special thank you to the organizations who are sponsoring this program. And if you have any questions during the presentation, please type them into the Q&A box on your Zoom control panel. We're going to address questions at the end of Dr. Landau's presentation. And so now, without further ado, I am going to turn this over to Dr. Landau.
Thank you so much for this opportunity to present on approaches to treating relapsed and refractory light chain amyloidosis. So by the end of this webinar, we're hoping that participants will understand the currently available definitions of relapsed refractory AL amyloidosis, appreciate the challenges associated with existing hematologic progression criteria, and become aware of what treatment options exist to treat relapsed and refractory disease. As background, I think you all know that light chain amyloidosis is a complex disease characterized by the production of light chains by bone marrow plasma cells. These light chains misfold and deposit in critical organs, and the organ involvement vary among patients. Treatment is typically targeted at the abnormal plasma cell clone, and in order to reduce or eliminate amyloidogenic light chain production and stop deposition and allow organs to heal. So we measure our response to treatment based on 2 factors: whether the plasma cell clone is eliminated and by evidence that the organs are actually being repaired. Evaluation and monitoring of both the hematologic and organ response during and after treatment is essential in order to understand patient's trajectory and guide management. So to really understand this, I show you the schematic of the disease pathology in AL amyloidosis so you can understand our response criteria. So here is a disease-causing plasma cell, and typically in healthy patients, we have a mix of both Kappa and Lambda plasma cells, but when it's pathologic, there is a monoclonal proliferation, which means only one type, grow too many, and these pathologic plasma cells produce antibodies And this is a heavy chain and a light chain of an antibody. And typically we have a mix of Kappa and Lambda antibodies, but in the pathologic setting, we have too many of one type. And this is the light chain. So this is a monoclonal free light chain. And it's this entity that misfolds into this substance called amyloid. And it's this amyloid that deposits in multiple different organs and disrupts organ structure and function. And the way that we measure these monoclonal free light chains is with this serum free light chain assay. The other thing to know is that an intact immunoglobulin, which is shown here, which is the whole heavy chain and light chain, can be measured by serum protein electrophoresis and immunofixation. This is more typically used in myeloma patients, but could be present in patients with amyloid as well. So the main goal when we're treating patients is we target the diseased plasma cell in order to improve organ function and prolong survival. All of our treatments that are approved to date or that we use to date target this plasma cell to eliminate the plasma cell. And when we do, we can expect that the circulating light chains are reduced. And that's how we measure our hematologic response. And once we get rid of the plasma cell and reduce the light chains over time, and it takes time, we can expect that organs dysfunction can improve. And that is measured by organ-specific biomarkers shown here. And if we achieve both a hematologic and an organ response, we can prolong survival. And this is data from our Italian colleagues showing that the percentage of patients surviving 5 years increases if you have no response to your plasma cell directed therapy. It is unlikely for patients to survive 5 years. If you do achieve a hematologic response, that percentage goes up, and certainly the patients who do the best are patients who achieve both a hematologic and an organ response. And how we measure hematologic and organ response is shown here, and these values have been validated, meaning that these values are studied in populations and shown to correlate with outcomes. If we start with a hematologic response, which again is the first measurement of our first goal of improving patient outcome, we can see that this is a plot which shows time and survival. And if we achieve a complete hematologic response, meaning a negative serum and urine immunofixation and a normal free light chain ratio, these patients on this blue curve have a very good overall survival, and patients who achieve what we call a very good partial response, as measured by a difference in the involved and uninvolved free light chain, meaning if your disease entity is a lambda, and if we can subtract the circulating lambda light, the Kappa light chains from the lambda light chains, and you meet this criteria, then you also have a good outcome. And this isn't distinctly different from patients who get a partial response or no response, who have worse outcomes. Similarly, if you achieve a hematologic response and then you can achieve a cardiac response as measured by the NT-proBNP, you have a better outcome. And if you can achieve a renal response as measured by a protein decrease by 30%, you have a better outcome. You're on this curve here, and renal response is actually not measured in overall survival, but actually renal survival. So a renal response predicts patients who are ultimately requiring dialysis. And if you have a renal response, meaning a 30% decrease in proteinuria, you have a very low chance of requiring renal replacement therapy or hemodialysis. So how do we define relapsed and refractory AL amyloidosis? This is a little bit of a conundrum, but refractory disease is really the failure to achieve a desired response. So I just told you that the best outcomes are patients who achieve at least a VGPR or a CR, and that predicts for overall survival. So that's our goal of anti-plasma cell therapy, to get to these benchmarks. And in general, the quicker, the better. So if patients have less than a VGPR after 2 cycles of initial therapy, we consider that a suboptimal response, and we consider changing therapy. There are some caveats to that, because some patients will have less than a VGPR, but their free light chain is still responding, just slowly, downtrending, and the organs are improving, and it wouldn't be wrong in that situation to continue therapy. Relapse is defined by when a patient has received their initial therapy, achieved an adequate response, and then again, we have to continue to monitor patients because there is a proportion of patients will have return of a disease. And so relapse is defined by reappearance of the monoclonal protein or doubling of the free light chain ratio with an abnormal ratio. And that's just reappearance of disease. And then progression is arbitrarily defined by an increase in the M protein or the free light chain beyond a certain threshold. And these definitions were really developed, again, arbitrarily by a consensus panel in 2004. And what we have to know is these definitions have never been validated or correlated with outcomes, meaning the level of the free light chain increase that predicts organ deterioration has really never been studied or defined. And the optimal timing for initiating therapy after relapse is really unknown. We do know that once organ function deteriorates, obviously, that seems like we should reinitiate therapy, but before that, it's a little bit of a conundrum. In an effort to figure out what to do, there has been a survey to really look at what are the practice patterns in the field, and really experts don't agree on the timing of salvage therapy. So in 2017, 50 experts were asked to describe their clinical decision-making and their progression criteria, because again, the progression criteria are arbitrarily defined and not it doesn't necessarily make sense to stick to it. And when these 50 experts were asked, the 3 main factors that were incorporated into clinical decision-making were the baseline free light chain values, meaning if when you were diagnosed, your free light chain was 100 milligrams per deciliter, we know that if your free light chain at progression goes to that level, that's probably not good for you, because that's a risk of organ deterioration. So a third of experts base their timing of salvage therapy based on the baseline of free light chain values. A quarter of experts base their decision-making on the disease severity at presentation, meaning if you were somebody who had severe disease at presentation, then the expert wouldn't want you to get to that level before reinitiating therapy, or the time between initial therapy and rising free light chains, meaning if you had relapsed soon after initial therapy, then it would probably make sense to reinitiate therapy sooner. But the bottom line is within these 50 experts, there was no agreement on a specific free light chain level, which mandates therapy. So 2 positions have been proposed. You can either start rescue therapy as soon as free light chain rise is detected, or you can delay treatment until organ progression occurs. And there's limited data, but what are the data? The Italian group, again, studied almost 260 patients who received treatment upfront with non-transplant therapy as initial therapy, who had required, and a third of those required salvage therapy. So they followed 259 patients, and 92 of them required salvage therapy. And when they looked at this patient population, they defined this high-risk dFLC progression based on rise in the difference between the involved and uninvolved free light chain of greater than 2 milligrams per deciliter, a greater than 20% rise of the baseline value at diagnosis, and a greater than 50% value rise reached at the best response. And they found that these 3 factors predict for a worse outcome. So if you met these criteria, you had a worse outcome with second line therapy than if you did not, if you started salvage therapy before you met these 3 criteria. So there's some indication that to start treatment early before you meet any of these criteria based on this cohort of patients. However, this data needs to be validated in an independent series. There are at least 2 studies that have been reported that relapse after high dose therapy and stem cell transplant may be asymptomatic for an extended period of time. And patients in this setting may tolerate some increase in free light chains. And there are other data to suggest that initiating treatment, and we know that initiating treatment, there's no free lunch. So as good as our therapies are, being on therapy is probably reduces quality of life if you're asymptomatic with a rise in your free light chains. We do know, though, that once there is cardiac or renal progression, there are worse outcomes. And you can see here, again, if you have a cardiac response, you do very well. And if you have a renal response, you do very well. But if you have a cardiac progression, meaning a rise in your NT-proBNP, or renal progression, which is defined by a greater than 25% reduction in your GFR, then you have worse outcomes, either defined by survival in the cardiac patients or the risk of requiring hemodialysis in the renal patients. So we certainly don't want to allow the free light chains to rise to the point that they cause organ damage. So starting therapy before organ damage occurs is truly the goal, although it's really not crystal clear when in any individual patient that is. So in summary, for the first part of this talk, response to treatment in AL amyloidosis has to be evaluated with the use of validated hematologic and organ response criteria. And even when patients get a response, patients require ongoing monitoring of the serum free light chains, the monoclonal proteins, and the organ biomarkers, because we need to look for the possibility of relapse. Progression criteria exists, but they're really not sufficient to guide management, and really we really need international collaborations to define new time points for response assessment and validate progression criteria, so we could really understand is it the rate of rise? Is it a free light chain number? Is it, and it's likely different in different patients, and the heterogeneity of the disease makes this difficult to study. Regardless, thoughtful consideration of the disease markers and the clinical picture must be considered when deciding to retreat a patient. The good news is that there are several options for salvage therapy. And how do we manage relapsed and refractory disease? We now know that first-line treatment for AL amyloidosis is well established, in the relapse refractory setting, there are many options, and again, no consensus. It was easier from 2015 to 2021, because that's when there was the emergence of the anti-CD38 antibodies, mainly Daratumumab, but also isatuximab, and these were showing lots of promise in plasma cell disease, and they were approved in multiple myeloma, but not yet available for patients with AL amyloidosis. And during that time, we studied Daratumumab and isatuximab in AL amyloidosis, and I can show you here these data from the initial study, showing a 90% overall response rate with an 86% VGPR rate, which I told you is the goal. And based on this data and the Andromeda study, Daratumumab is now incorporated into first-line therapy with Dara VCD. And so most patients, I would say, are getting Dara VCD as their upfront therapy. So now upfront therapy, first-line treatment is very straightforward. However, second-line treatment is not so straightforward, because once you either are refractory to Dara VCD or relapse from Dara VCD, there's not good guidance to determine management, but there are several treatment options. Here I show the classes of drugs that we use most commonly and that are approved for the individual drugs that are approved for patients with multiple myeloma, with the only approved regimen for AL amyloidosis being Dara VCD. So in italics, you see Dara, bortezomib, and cyclophosphamide. But all of these other drugs are available for patients with multiple myeloma and are being studied in patients with AL amyloidosis, but we really don't have any comparison, and we really don't know which drug is best for our patients with AL, and they all have caveats of toxicity, efficacy in different patient and have been studied in small trials in different patient populations. The good news is we also are developing novel treatments. There's novel targeted therapies, there's novel immunotherapies, there's T-cell redirecting therapies, and now there's amyloid-directed therapies all being studied. And really, in order to get any of these treatments really potentially available for patients with AL amyloidosis, I have to say that when available, if somebody is considering salvage therapy, if there is a clinical trial that you are eligible for, it's really imperative to try to participate, because that's the only way we'll ever get these drugs approved for our patients. So what are the treatment options for refractory disease to date? Again, we define refractory disease as the failure to achieve a desired response to our standard upfront therapy, which is Dara VCD. And that is really accepted that less than a VGPR after cycle 2 is considered a suboptimal response, and you should consider changing therapy, except of course if the free light chains are downtrending and the organs are improving, despite not achieving a VGPR. I want to make that clear. So what are established and emerging therapies? High dose melphalan and stem cell transplant is one of our tried and true options for patients and has a long history of good outcomes, but patients have to be eligible for this therapy, mainly dictated by their performance status, their cardiac function, their renal function. IMiDs, the immune modulating agents, lenalidomide and pomalidomide, have been studied. These are standard drugs that we use for patients with multiple myeloma. They do have more toxicity in patients with AL amyloidosis and a lower response rate than the proteasome inhibitors, but still can be effective in some patients with AL. The proteasome inhibitors, ixazomib, has been studied in the second line setting in AL amyloidosis, and carfilzomib also has a high response rate, but can be toxic for patients with cardiac involvement, but can be very effective in selected patients. And excitingly, Venetoclax is being studied in this patient population because translocation 1114 is a cytogenetic abnormality that is present in the abnormal plasma cells in about 50% of patients with AL amyloidosis. And patients with this cytogenetic abnormality are really uniquely responsive to the BCL2 inhibitor Venetoclax. And there's data that have been presented and published in a retrospective series, actually more than one retrospective series, but here is just one showing an 80%, almost 80% VGPR-CR rate in patients who have been treated in relapsed refractory disease with Venetoclax. And I would say if somebody has translocation 1114, I often go to this as second line therapy for patients or with AL amyloidosis, and they're again better to be given in the context of a clinical trial. There are some clinical trials that are ongoing and others are planned. So if you have availability to a clinical trial, that's more optimal than getting this drug, which is not always available outside the context of a clinical trial. And then for, again, the patient population who responds to initial therapy and then relapses or progresses, there is no consensus. Again, I can't say this enough on when to treat. And again, it has to be a thoughtful decision. So what are the established therapies in this setting? Watchful waiting, again, is appropriate in some patients. Retreatment with VCD, Dara-VCT, or Daratumumab alone can be effective if you responded well to this treatment and have been off therapy for quite some time. Venetoclax alone or in combination may also be used in patients with translocation 1114. High dose therapy and stem cell transplant, sometimes we collect patients during their initial therapy, but if they achieve a deep remission and their organs are improving, we don't necessarily transplant them. Although, again, this is another controversial topic where we'll have a study to address this question. But when patients relapse, they can get a stem cell transplant at that time. Again, patients in the relapse setting often have improvement in their organ function, and even if they weren't candidates for a stem cell transplant in the upfront setting during relapse, they may be eligible for a stem cell transplant. And even patients who did get a stem cell transplant in their as part of their initial therapy, if you had a long duration of response, a second transplant is a reasonable option. Again, the IMiDs, with all the caveats I discussed, are especially in combinations, can be considered. Proteasome inhibitors can be considered in this setting. Isatuximab, if is another anti-CD38 antibody that's being studied. And then there are these emerging therapies, and I think this is where my excitement lies. There's a target called B-cell maturation antigen that is present on pathologic plasma cells and has been exploited for therapy and in multiple myeloma, and now will also the amyloid community is following suit. So belantamab is an antibody drug conjugate that has been improved in multiple myeloma. This agent is in clinical trials in Europe for patients with AL amyloidosis. Teclistamab is a bispecific T-cell engager directed against BCMA. It actually is like a dual antibody. One side engages the T-cell, one side engages the BCMA on the plasma cells, bring those cells together to effectively use your immune system to get rid of the pathologic plasma cells. This has recently been approved in multiple myeloma and may be available for patients who meet criteria for multiple myeloma and AL amyloidosis, but clinical trials with this agent and other similar agents in specifically AL amyloidosis are planned, not yet available, but are planned. Abecma and Carvykti, the new hot topic, chimeric antigen receptor, CAR T cells, again, another T cell redirecting therapy to use your immune system to effectively eliminate pathologic plasma cells. Both these products are approved in multiple myeloma. We have been able to get some of these drugs after many lines of therapy for patients with AL amyloidosis, understanding that, and while these two agents are not, I don't know of any specific AL-specific trials being planned with these two agents. There is an agent that has been a CAR T cell directed against the same target, the BCMA, that was developed at Hadassah Hospital in Israel, which is included AL patients with a very high response rate in that trial. And that drug, hopefully, I'm hoping to do the inaugural CAR T cell clinical trial with this Nixella product in hopefully by early next year. But I think that there will be more of these CAR T cells available for patients with AL amyloidosis moving forward. I think that it is important, again, if possible, to be treated on a clinical trial given the specific toxicities with these products, which are really very effective for patients, but do have unique toxicities. Again, so studies with these or similar agents are ongoing or planned, and again, if available, treatment should be in the context of a clinical trial. Other considerations in relapsed refractory AL amyloidosis, the role of maintenance therapy has not been established. We're doing a maintenance therapy study with ixazomib here and in high-risk patients. And the results of those studies will be forthcoming. We also have to understand how to manage organs that fail despite adequate hematologic disease control. And there is the opportunity for organ replacement, meaning cardiac transplant and especially kidney transplant, in patients who have organ failure despite good hematologic disease control. But given the complexity of AL amyloidosis as both a hematologic and organ disease, it's often a conundrum for hematologists and subspecialists who are trying to manage our patients, and really a team approach inclusive of the oncologists, subspecialists, nurses, APP, social work, dietitians, caregiver support, and community resources are essential in order to provide adequate care for our patients. There is an essential role. You can't just treat patients with plasma cell directed therapy without really understanding the complex nature of this disease and the essential role of supportive therapy in managing these patients, whether it's diuretics, blood pressure support, lymphedema therapy, nutritional support. There's a lot of things to think about, and I would say that supportive care is just as essential as plasma cell directed therapy in this patient population. We didn't touch on the anti-amyloid therapies, which are being studied to hasten organ improvement in patients. But hopefully data on these agents will be forthcoming as well. So in conclusion, there is not a one-size-fits-all approach to managing patients with relapsed refractory AL amyloidosis. I hope I made that clear. Thoughtful consideration of both the hematologic and organ disease, the prior treatment response, and any toxicity to prior therapy has to be considered when we're deciding on a treatment approach. In patients who have a good response to prior therapy and restoration of organ function, close monitoring in the setting of slowly rising free light chains may be very reasonable. The goal of second-line therapy is really the same as the goal of first-line therapy, to achieve a rapid and deep hematologic response and prevent organ deterioration. So we want to treat you before the organs deteriorate, and we want to get the light chains down so that they, again, the organ compromise doesn't occur in the second-line setting. Gratefully, novel agents with high response rates are likely going to be studied in this setting, and participation on clinical trials is really essential to define AL-specific toxicity and efficacy and ensure these agents are eventually approved for our patients with AL amyloidosis. Thank you for your attention. This is where I sit at MSK in New York on the East River, and fortunately today is the first sunny day in quite some time in our area. So
what a view. That looks amazing. Well, thank you so much, Dr. Landau. That was fantastic. And I know we get a lot of questions routinely from patients with relapsed refractory AL amyloidosis, and really this webinar is timely. And so I'm just going to show a quick reminder to folks. So if you do have any questions, please type them into the Q&A box. I see that we've got a number in there already. So I'm going to start going through those, but please feel free to share them as you're thinking of them. So one of the questions I thought was a great question to start with is whether, in your experience, do patients feel or notice physically if they're headed towards relapsed disease, or is it something that is really strictly caught up or typically caught with labs? And when you're finding it in labs, is it happening in tandem between both the free light chains and the organ biomarkers, or is it typically something where you see the light chains first and then see the organ biomarkers?
That's an excellent question. And again, the heterogeneity of the patient population really comes through in this setting. So most patients, we see the free light chains rise before we see any evidence of organ deterioration, but when you're being followed, we follow all of these biomarkers very carefully and track patient symptoms. That is, there are a few patients that I would say their symptoms preceded the rise in light chains or the rise in biomarkers. And that's why we ask patients every time. We really try to determine how patients are feeling, what their performance status is, what their level of dysfunction is, or, how do you feel compared to how you felt when you were first diagnosed, how you feel compared to how you felt when you were at your best. And really, I think all of it comes into play, and there's not, again, a one size fits all. Most of the time, we do see the free light chains. Gratefully, we do have a good biomarker. Most of the time, we see a rising free light chain before patients will notice any organ deterioration. I tell patients, I should follow you closely so that I can be worried before you can be worried. But occasionally, and there's about 50% of patients who will require treatment for sure before they meet that standard progression criteria. And that's how we know our progression criteria are really suboptimal. So it's a difficult task.
Yeah. How frequently, or how, I guess, at what interval are you typically monitoring patients to look for relapse?
At the very least, probably every 3. It depends on how deep their response is and how long after initial therapy. So typically in the first 2 years after initial treatment, I look at every 8 weeks. Thereafter, I'll extend it to every 12 weeks. In rare circumstances, I go to every 4 months and every 6 months. But if patients are in a CR for a long time and there's no organ involvement, there's very few patients that I'll check every 6 months, but more often every 3 months or every 4 months. And if patients are looking like things might be going up, then every 8 to 12 weeks for sure.
And then can you explain a little bit about what minimal residual disease is and how it relates to this topic?
Yeah. So again, I show you our response criteria, which have been validated, meaning that if you get a deep response by the definitions of CR or VGPR, we know that that tracks with overall survival of our patients. Because there are sensitivity of measuring these circulating light chains have increased, and the sensitivity of detecting abnormal plasma cells in the bone marrow have increased, we are now able to say, can we eliminate the plasma cells with a level of sensitivity much greater than we had in the past? And if we get rid of all the pathologic plasma cells by something that we call flow cytometry, meaning if we look in the bone marrow and we look at 5 million cells, can we not detect a single pathologic plasma cell? At least in the myeloma community, if we use that sensitivity, we see that if we get people in a complete hematologic response by the serum biomarkers plus an MRD negative response, meaning minimal residual disease in the bone marrow, with negative, meaning we can't detect one abnormal plasma cell within 5 million, those patients can have even prolonged remission duration and better overall survival. And in fact, in a disease like myeloma, where we can we really continue therapy in perpetuity. We're now, if you have MRD negative or what we call sustained MRD negativity, we're now even considering stopping therapy in a group of patients. In amyloid, there's been MRD negative testing by flow cytometry. There's been MRD negative testing by the circulating marker by next generation sequencing. There's an attempt to define MRD negativity in the serum by mass spectrometry, which is something that I've been focused on, because doing bone marrows regularly is not pleasant for anybody. And the entity that actually causes the disease is the circulating light chain. So if we can use a more sensitive test than the serum-free light chain assay to detect, is there any pathologic circulating light chain by something called mass spectrometry, does that correlate with outcomes, and can we test that more regularly than doing bone marrow tests? And will that predict long-term organ improvement and survival? And so it's a area that we're very focused on in terms of understanding what its implications are in amyloid, but we don't have the data yet to say that this is our benchmark.
Okay. We've got a lot of questions coming in, so I'm going to try to group some of these as much as I can. There are a few questions about like what percentage of your patients do you see go on to relapse, and are there predictors that would kind of indicate that a patient might relapse earlier or is at higher risk?
Yeah, so I think that the patients who achieve a complete hematologic response are definitely less likely to relapse and more likely to maintain their remission for longer. So that's number one. We don't have unfortunately, we don't have long-term data from the upfront experience with what most patients are currently receiving, Dara-VCD, as initial therapy, because again, this regimen was only approved in 2021. In the transplant era, where again, any eligible patient was offered a transplant as part of their upfront therapy, the event-free survival, the need for second-line therapy was about 50% at 4 years. But you have to understand that that's a median. And so it's not at the 4-year mark, everybody needs second-line therapy. It means at 4 years, 50% of patients will have needed therapy and 50% of patients have never needed therapy. So, and again, patients are a heterogeneous group, so it's hard to predict. But I would say if I had a gestalt, about 50% of patients will need therapy with our currently available data on what has been available.
Okay. And then there were a number of questions about Venetoclax. And can you talk a little bit about whether that's used as a single agent therapy in combination with Dara, with bortezomib, with different regimens?
So in multiple myeloma, it's been studied with Dara, with bortezomib and Dara, and as a single agent. I think that again, we have small cohorts of patients who've been treated in the relapse setting in AL amyloidosis in a retrospective setting, and we don't have the prospective studies. There are several trials that are ongoing or planned, both with Venetoclax as a single agent, which can be very effective, also with the proteasome inhibitor ixazomib, and with Daratumumab and Velcade. So
Okay.
I think that we just don't have the data yet. I think I use it in all sorts of ways,
Mhm.
but depends on the patient, depends on what the level of the light chain is, what is my goal, what they've been responding to, when they have to consider all of the issues at play.
Okay. Another question, I saw a couple of these. If a patient either doesn't respond to DARA or relapses after DARA, what are the chances that another anti-CD38 antibody would be effective for them? Where would you typically turn in terms of next line therapy?
Yeah, so progressing on Daratumumab, I would not turn to an anti-CD38 antibody. If you receive DARA and you had a great response to DARA initially, and then relapsed, I think it's it's certainly a possibility, and a good possibility, that you can respond again to Daratumumab or isatuximab, the other anti-CD38 antibody. So retreatment after a response and progression off of Daratumumab is definitely reasonable. What also is, so no in the setting of progressing on DARA, yes in the setting of achieving a response and then relapsing. And then the other area that we really don't have any data on is patients who are on DARA who have achieved some response, but not the optimal response. Do we keep them on DARA and add another agent, or do we take away the DARA entirely because you haven't achieved your optimal response? And I think that really there's no data to guide us there. And I think that has to be a thoughtful decision based on what's going on with the patient and how quickly they responded and what was the level of response to their initial DARA to it. There.
Another question. So we know that one of the keys to improving outcomes for patients in AL amyloidosis is early diagnosis and treatment. Do you think either screening earlier or initiating treatment earlier would decrease the amount of relapse that you see in clinical practice?
So I think that the most important, what's very important is actually early diagnosis and before organ deterioration occurs. Do I think treating earlier will prevent relapse? I can't say, because really you have to understand it's both it's a hematologic and organ disease. So the biggest issue is that the hematologic disease is not as big of a problem as the organ deterioration. And what we know is the longer that you have the disease, the more the more at risk the organs are for deteriorating, and it becomes harder to treat in that setting. So screening would be, if we could really figure out how to screen populations, because it's a rare disease, because it's been difficult to spread this message. Patients are routinely misdiagnosed and have to go to multiple subspecialists before they get their diagnosis. I don't know that treating patients earlier will prevent relapse, but it certainly would prevent organ deterioration. And it's really, one of my main focuses, and all of us in the field, is really, it doesn't matter how good your drugs are against the plasma cells. If patients already have very sick organs, I'm not sure that we can rescue them with our treatments.
One question, is it possible to have normal light chain levels, but still have a low level M spike? And what might the significance of that be?
Normal light, you're talking about after a response.
Yes, sorry.
So that's also a conundrum, because a monoclonal gammopathy is common, and it's not necessarily, it's hard to know, because again, patients who don't clear their low level of M spike still meet criteria for a very good, and have normal light chains, still meet criteria for a very good partial response, but don't necessarily meet criteria for complete response. But whether or not that small M spike is contributing to any organ deterioration is not really known. So there may be some population of plasma cells that still exist that make this intact monoclonal protein, but if the organs are continuing to get better, that's probably not playing into the level of amyloid deposition in the organs. However, it does speak to the fact that you have not eliminated all of the pathologic plasma cells, and that there's a nidus for relapse that one has to be cognizant of.
Okay. And then can you explain a little bit about the difference between the Kappa Lambda ratio and then the difference, the dFLCs? Like what are the significance of each, and how do they inform how you manage patients?
Yeah, so the Kappa Lambda ratio is really just the proportion of the pathologic protein versus the uninvolved or non-pathologic protein. And it really has never been validated as a other than normal. The level of the ratio just gives us a clue of how much pathologic protein is there compared to the level of the circulating norm, because we have to understand that we don't want to eliminate everything, because we all have normal plasma cells that we need. And so there's and that's why the free light chain assay is not a great assay, and we need something more sensitive, because the free light chain assay detects both the pathologic protein, not just say you're a lambda, not just because once you eliminate the pathologic plasma cells, you're going to have lambda plasma cells that are normal, healthy. So the ratio of the abnormal and normal is just a proportion, and is influenced by things like renal failure is the big one, that the ratio can, both the kappa and the lambda, go up when you're not clearing, but it's not necessarily the pathologic light chain in that setting. And you can have a normal ratio when you have too much of one a pathologic level of one protein, you see the ratio very skewed. But again, it doesn't necessarily correlate with outcomes as much as what's been studied is this difference between the involved and uninvolved free light chain, meaning one, what the level of the involved or the pathologic light chain compared to the level of the involved free light chain, uninvolved free light chain, as a subtraction function.
Okay. Well, I know we're at time. We received more questions than we were able to get to. And so we're going to follow up with Dr. Landau and work to get everybody answers to the questions they'd asked. I'd like to thank Dr. Landau for being so gracious with your time and with your expertise. This was truly phenomenal. For everybody who's joined online, you will be asked to complete a post-webinar survey. If you have a few moments, it's short and brief. It really helps us as we plan these webinars moving forward. So thank you to Dr. Landau, to everybody for joining us today, and we look forward to seeing you next month. Thanks, everyone.